like to thank our sponsors, without whom this would not be possible: Bristol Myers Squibb, Amgen, Karyopharm Therapeutics, AbbVie, Adaptive Biotechnologies, Genentech, Oncopeptides, and Takeda Oncology. So as I mentioned, we have Todd and Diane Kennedy here with us today. They are co-leaders of the SoCal Myeloma community chapter that you're a part of now, and we're so happy to have you, as I mentioned. Todd was diagnosed with multiple myeloma in 2017, and since that time, he and Diane have become active patient advocates in the myeloma community. In addition to serving as the co-leaders of the SoCal Myeloma community chapter, they are also myeloma coaches. It is now my privilege to introduce our key speaker to you, Dr. Amrita Krishnan. Dr. Amrita Y. Krishnan, MD, is a professor of the Department of Hematology and Hematopoietic cell transplantation. She's also the director of the Judy and Bernard Briskin Center for Multiple Myeloma Research. Dr. Krishnan is the chief of the Division of Multiple Myeloma and currently practices in the City of Hope Medical Center. Dr. Krishnan completed her medical degree at the Albany Medical College in New York as a part of the combined BS-MD 6-year accelerated program, where she was selected for the Alpha Omega Alpha Honor Medical Society. Her postdoctoral training comprised residency and internship in the Strong Memorial Hospital Department of Medicine at the University of Rochester, as well as fellowships at the City of Hope Medical Center, Harvard Medical School, Beth Israel Hospital, and the Dana-Farber Cancer Institute. Dr. Krishnan is a diplomat of the American Board of Hematology. She is also active in several professional societies. She is the former chair of the American Society of Clinical Oncology Plasma Cell Committee and former co-chair of the Center for International Blood and Marrow Transplant Research Plasma Cell Committee, and former chair of the Blood and Marrow Transplant Clinical Trials Network Myeloma Committee, and is also a subcommittee member of the American Society of Hematology, American Society for Blood and Marrow Transplantation, a steering committee member for the Multiple Myeloma Research Foundation, and the North American representative for the International Myeloma Foundation. She's also a member of the State of the Science Committee for ASTCT, focused on defining the next generation of therapies in myeloma. Dr. Krishnan has authored almost 200 articles, abstracts, and book chapters, and she is a reviewer for several journals, including American Journal of Hematology, Bone Marrow Transplantation, Hematologica, Blood and Biology of Blood and Marrow Transplantation. An active researcher, Dr. Krishnan was instrumental in bringing successful transplant therapy to HIV patients with lymphoma when many believed such patients were too weak to tolerate the procedure. She's currently the principal investigator of an innovative trial utilizing zinc finger nuclease. Excuse me, like a thing in my throat. She is currently the principal investigator of an innovative trial using zinc finger nuclease-based stem cell therapy for HIV treatment. She is also the co-chair of one of the largest myeloma transplant trials in the United States, evaluating the role of minimal residual disease to guide maintenance. Again, welcome, Dr. Krishnan. We're so privileged to be sharing this time with you, and thanks for joining us tonight. In just a few minutes, we will begin our conversation with questions and answers for Dr. Krishnan, but first I will turn it over to Todd and Diane to get us started. So take it away.
Yay. Wow, you read that background, and I want to do a standing ovation, a round of applause, actually, for those incredible accomplishments. And I tell you, Dr. Krishnan, we are so privileged and so grateful that you're joining us here today. That bio just blows my mind that we have you here in Southern California, and we get to learn from you tonight. And you're so generous with your time and expertise, and it's especially noteworthy considering that you're just coming off of the American Society of Clinical Oncology meeting literally just hours ago, and you're able to join us tonight. So thank you for being here. Thank you for what you do for all myeloma patients around the world. And thanks for what you've done for me and Diane too. And you have some of your other patients on here. This month, I'm celebrating my 3-year stem cell birthday. And I credit my remission to you and the expert team at City of Hope. So we're forever grateful. So a lot of gratitude on a lot of levels, but thank you for being here tonight. Before we get into the conversation, let me just hit on a couple points on the agenda. So we're going to just make sure we get you up to speed, Dr. Krishnan, on who's on the line here tonight with just 2 quick polling questions, and then we'll kick it straight over to this conversation. And for the group, Diane and I are going to facilitate a conversation for about 20 minutes or so with some questions we think that might be relevant to everybody, whether you're newly diagnosed or further along in your journey. And then we're going to just open it up for about 20 to 25 minutes for you to ask your questions. And feel free during this first portion to type in some questions into the chat box now that you know how to use it in Google Meets. And we're going to pause after that first section, look through some of the questions, see if we've answered them, see if there's recurrent themes, and then we'll get right into that. So that I think is going to be extraordinary. And then Diane is going to transition into an update on some of the community events, things that are happening in your local county or some other tips that you might have regarding living with myeloma. And then we'll turn the recording off and have that remaining 15 minutes for anything else that's on your mind that you'd rather just kind of share with the group and get to know each other a little bit more in an unrecorded session. So that's the agenda. Sound good? All good? Okay. Next slide. So here's how we do the polling. And Audrey, you want to help?
Yeah,
kick
of course.
this off?
So at the bottom of your screen, you should see a triangle, a square, and a circle. That's the activities icon. If you click on that, you should be able to see a list of different activities, and one of those is polls. And as I'm saying this, I realize that I haven't launched the poll questions, so there they are. We will be reading for those that for some reason aren't able to access the polls, but the exciting part about this Google Meet update is whether you're on a cell phone, a tablet, or a laptop or a desktop, you should be able to participate in these polls. So I opened them both at the same time for the lack of time that we have. Yeah. So the first one says, when were you or your loved one diagnosed? We have different options of less than a year, 1 to 4 years, 5 to 10 years, or 10 plus years. And then the second question is asking, what is the status of your disease? Is it MGUS or smoldering, newly diagnosed, in remission on treatment, in remission not on treatment, relapse refractory on treatment, or relapse refractory not on treatment? So we'd love for you to take a couple minutes, look at those polls, and answer them. It looks like we're getting lots of votes in, which is exciting. Diane, you want to talk about those results that we're seeing?
Sure. It looks like 1 to 4 years is the most common answer as far as diagnosis, but we have 10 votes for that, but we have 4 votes for the 10 plus years. So that's, we like that and keep those going. And then down when we look in the status of the disease, again, in remission on treatment is the most popular response with 11 votes in that area. We review all these just so people know. I know you can see them, but if for a lot of people that get the recording afterwards, they don't get the poll results. So that's why I stand here and sound like a commentator. It's just because other people won't know the average or the numbers that are on here. So we have 6 people with a year or less, 13, 1 to 4, 0 votes in the 5 to 10 years, and 4 votes in the 10 plus. And then for MGUS and smoldering, 4. Newly diagnosed 2, in remission on treatment 12, in remission not on treatment 0, relapse refractory on treatment 5, and a relapse refractory not on treatment 1. So that covers
there's some people that are new to this whole game, trying to drink from the fire hose to learn as much as possible. We're glad you're here. There are other people that have been on this journey for a long time that are staying current because the news breaks so quickly, even like this week at ASCO. So we work really hard in each one of these meetings to make sure that there's something for everyone. And thanks for participating in the polling. That gives you a good snapshot, Dr. Krishnan, of who we've got on the line. How about next slide? And I'm going to, just in the interest of time, not spend any time on this other than to say we reviewed it last time, and it's a great resource, the Cure in 5 initiative. And, get educated, get empowered, and that's what we're here to do with Dr. Krishnan today. You can go back a slide, Audrey, and just take the slides off, and so we can see everybody. And now we will.
Oh my goodness!
Just stop sharing.
Just stop sharing.
Just stop.
Now you can see everybody. Now we can see everybody's faces. It's like we're in a nice conference room at one of the cancer centers, and this works out beautifully. And we'll leave it like this so you can all see each other. Like Audrey was showing earlier, if you go down to those dots and you change your tiles, then you'll be able to see everybody that's here. And What a great looking group. Thank you again all for joining. So let's jump right in but before we dig into the science, let's start with a conversation to just get to know you a little bit better, Dr. Krishnan. We heard your bio, which is great, but recently you and I had a chance to sit down, and in a conversation, you said to me that you get to do one thing that you love all day, every day. Why did you find your way to myeloma, and why do you love it so much?
Well, first of all, thank you, Todd and Diane, for the invitation to speak. What a great group. And thank you all the work you're doing for our Newport Beach office as well, in terms of, we should put you guys on the payroll from our City of Hope in terms of just everything you've done for building our Orange County community. And we're very excited. Next year, we're going to open up the Irvine Cancer Center. We had the, I forgot what they called it. It wasn't a groundbreaking. It was a
Topping off.
Thank you.
Topping
Yeah,
off.
exactly. Last week. So that was also incredibly exciting. And so we're really making progress, and having that cancer center, just, I mean, so everyone knows that's not just an office. It's going to be a true City of Hope cancer center with everything there: operating rooms, radiology, radiation oncology, everything. And we're planning on doing auto BMT CAR T down in Orange County as well, as part of our timeline. So we're incredibly excited about that.
Oh, that's great. I didn't know BMT was coming there too. That's wonderful news.
Yeah. We obviously recognize there's a lot of patients who don't, down from South County, who don't want to make that 60-mile each way drive. So
yeah.
So we're excited about all the future down in Orange County.
So why do you love myeloma so much? You with those brains, you could have focused on any area. You picked myeloma.
I think myeloma is exciting just because the advances happen so quickly, and every time you think you've sort of reached a certain plateau, you just blow right by it. And frankly, we thought daratumumab was an incredible game changer, and it was. We did the phase 1 trial at City of Hope, and people have heard me say we filled that trial in 2 weeks. It was such a demand. But that was 2012. Dara got approved. I mean, now and so things since then is sort of, but then we had CAR T cells, and that, again, another game changer. Who would think people who had 8 previous therapies could have response rates of 80 to 100%? I mean, it's incredible. And then so having our first CAR T approval this year, again, incredibly exciting. And then the bispecific T cell engagers, which was what I was talking about today at ASCO. That's a whole new class of drugs that just sort of came out of the leukemia space. They've had one approved, but again, just exceeded beyond our expectations in terms of responses. So, we keep getting newer things and so that's what keeps it incredibly exciting. And then also just understanding the biology of myeloma, like one of the targeted therapy with drugs really to affect certain genetic mutations. That's also something that's very exciting in the field.
You never get bored. It stays fresh.
Yeah, and it's a learning curve even for us with these new drugs, new side effects, and how to manage them and dose and all these things. So, frankly, we don't even use a lot of the drugs that we used when I first started in myeloma. So that tells you how quickly things change.
Yeah, I think that's another case when you look at the polling that we just showed. You have people that are newly diagnosed, and you have some that are 10 plus veterans. You also have some people that are, in that 1 to 4 time frame, where we know that since there is no current cure, there's a chance that relapse is in the future. And with it changing so quick, it behooves patients to stay on top of the science to a degree as well. And even if you have been at this for 10 years, it's changing rapidly. So no matter where you are in your myeloma journey as a patient, you kind of need to participate in programs like this to stay on top of the science.
Yeah, I mean, as I said, CAR T got approved in March. There's another CAR T that's going to probably get approved at the end of this year, the one that was presented also an update today at ASCO. So we're going to have 2 CAR T products for patients. And there's been data presented using CAR T even earlier in the course of the disease. So, 5 years from now, even what you get for newly diagnosed myeloma may be completely different. We're going to be opening a trial with bispecifics for newly diagnosed myeloma, for example. So it really, that's what I mean. Things change so quickly.
I think something that I think this group, you'd be preaching to the choir to talk about the importance of a myeloma expert. I think pretty much everyone on here understands that, just and knows why, because it's changing so quickly. But what thoughts do you have on seeing, because not everyone here has the opportunity to see a myeloma expert each month. At what points in your myeloma journey do you think that it's important to make sure you have a myeloma specialist quarterbacking the whole thing?
Well, I mean, I would say a couple of things. Number one, we're lucky we have a great myeloma team. So we lost one of our people, Dr. Karanis, so some of you may be her patient. As you know, she went to the FDA, which is still good for us. Always good to have a friend at the FDA. So, that's fantastic. She's she's a great asset to them and will help us in the myeloma world. So we have 3 other doctors, and then we just hired 2 more. So we're having a great doctor from Washington University, St. Louis, who's going to be joining us in August, and another CAR T expert who's going to be joining us from the University of Minnesota in September. So we're really excited that our program's expanding. And so yeah, in terms of your question, Diane, I think what we know is outcomes are better if you see people who are experts in myeloma. We're going to be publishing our just City of Hope data in terms of compared to the general data of survival for myeloma, and just showing that our survival is certainly above the expected, which is very encouraging. But I mean, obviously, you don't need to come every month to get regular chemotherapy. Make your life easier, right? So certain things you can be done with your local oncologist. We work with all the local oncologists as well. And so generally it's at diagnosis to come up with a treatment plan. If you're thinking about transplant, after a few cycles of chemo, to assess that transplant question. If chemo is not working, obviously that's another decision point to have that discussion again. Or if myeloma comes back, I would say those are sort of the decision points that I think are helpful. And the other thing I think, it does help to come in and actually see the physician, because a picture is worth 1,000 words. And, it's, a 2-line email from someone is not the same as someone sitting there for, reviewing your records and having a discussion with you. So it really is worth that.
As you meet with patients,
more locations, that's also a little bit helpful.
Oh, it's awesome.
Some telehealth capability as well, which also makes a big difference for people.
Yeah, as you meet with patients, what factors do you consider when you're deciding on individualized treatment plans for specific patients? What things are you looking for that makes you decide, oh, you're going to have DARA, or you're going to, do?
I mean, so it depends in terms of just patients' other medical issues is one. Their type of myeloma, how aggressive it is it? With CAR T cells, it's a whole different actually discussion because of the logistics of CAR T cells, the time to actually get CAR T collected, manufactured. So that has implications again on how aggressive is someone's disease, how quickly do they need treatment. Also, how far away do they live from the center? You need to stick around. We actually have pretty strict requirements of how close you have to be for several weeks after the CAR T infusion, and also having a support team in terms of in place for that. So CAR T is in a way actually even more intense in its monitoring needs than an auto transplant, just because of some of the unique toxicities to it. So that's some of our decision-making process as well, is, what kind of support does someone have? How close can they come and live close to our center for that period of time? So those logistical issues. Same with clinical trials, unfortunately. So fortunately, we have a lot of amazing trials. 3 of our trials are being presented at ASCO. It just tells you that we have a lot of access to great stuff. The downside is those trials are only being done at Duarte right now. So eventually they'll be done in Orange County, but they're not yet. So again, that's the logistics of traveling for those trials. And I am sympathetic. It's not that, as you all know, it's not that you come in, check in, and then go get your study drug, right? It's basically you're going to commit the whole day to being there. And so, that again is also the logistics. And even for people, when they think about a trial, those are important questions to think, is that feasible for you to make those trips? And so those are some of the things that we think about when we discuss treatment options.
There are a lot of factors then that do go into that individualized therapy. I know I've heard some people say, oh, everybody gets RVD, but actually an RVD is great for a good percentage of patients, but there are a lot of factors at various points in your journey that, it's not just RVD. There are a lot of factors that figure into what is the right treatment at a certain point in time. Sounds like you're saying.
And even RVD is sort of changing now. It's sometimes with daratumumab, sometimes we substitute carfilzomib instead. So you're absolutely right, Todd. There are definite nuances to all of this.
Since we have patients here and we're talking about different places to see an expert and everything, do you have any suggestions for the group on how to get educated just on the basics and how they should prepare to make the most of one of their clinical visits? Any expectations, or how what do you think is the best way for a patient to be empowered, for shared decision making and just to make the most out of the time with either you or their specific expert?
Well, I think things such as this organization are fantastic in terms of providing sound advice as well as links and resources to information about myeloma treatment. So I think that's fantastic. Unfortunately, we have only, how can I put it? Time is not unlimited in a clinic day. We see 30 patients a day in clinic, and absolutely, we'd love to spend 2 hours with every patient, but as you can imagine, that's not feasible. So I think one of the things in terms of making the best time is to have sort of, people certainly have a lot of questions, absolutely understandable, but having the expectation you're not going to be able to get every question answered in that first visit. And frankly, it's too much information anyway to be absorbed. Mm-hmm. So really you pick, what are my top 3 questions that I need to know today? And have the expectation that, fine, if I don't get my questions answered today, that's okay. I can make another appointment and discuss further. So it's a process, right? And sometimes we won't have all the answers because a lot of people's questions are more of the unknown. And that was only, again, time is really the biggest factor in that, assessing response to treatment, assessing side effects of treatment. So I think that's the biggest thing, not feeling the need that you need to get every single question answered before you leave, because it creates a lot of anxiety for patients.
Yeah.
And
I have a question about second opinions. How does City of Hope handle second opinions, and what are your thoughts on second opinions? I know as patients, people get nervous about, seeing someone else and feel like they're cheating on their doctor or whatever. And what are your thoughts on it, and how does City of Hope handle that?
We certainly do a lot of second opinions. Myeloma is not it's a disease that has many options, which is terrific. I think if there was only one option, everyone would give you the same answer. So it doesn't mean that the other option is a bad option. It's just a different choice or a different road, I would say. I think one of the things I would say is if you come to a transplant center and that's one of the things that we discuss, I don't think that I would sort of spend the time then trying to debate, well, why did this other doctor say no transplant? That's not really, you're kind of wasting your second opinion then, because, I don't think a transplant is going to spend the time telling you why someone says no transplant. That's not using the best of their expertise. Mm-hmm. So in terms of, I think, understanding what you want to get from that second opinion, right? So especially that discussion about transplant versus no transplant, there is no right answer. Myeloma experts, we spend hours of debate because you can look at the data from both ways. So to have don't have the expectation that you're going to go in there after reading the articles and come up with a clear answer, because there isn't. And it's really, again, understanding there's just different roads. And I think a lot of people have, it certainly is a challenge, and sometimes it's sort of the analysis paralysis, right? Of having too many choices makes it more difficult. But I think that's part of it. Getting a second opinion doesn't mean that opinion is going to say you have to do this. That's not what really it means, right? It just shows you another road. But ultimately you have to make the decision of what road feels right to you.
Yeah, that makes sense. I think one of those roads, Dr. Krishnan, and you mentioned it a bit already, is a clinical trial. And sometimes that's why it's really great to get that expert input, to get a better read on what clinical trials might be right for you. How does that conversation go? What do you tell patients when they're thinking about a clinical trial, and why should they consider it? I think a little bit, it's National Cancer Survivor Month right now, but the only way you become a survivor go from a patient to survivor is by the insights that come out of these clinical trials. So they're so important, but how does that conversation go? How do you like talk to people about why they really should think about a clinical trial?
Well, I guess there's two kinds of trials, right? So there's a trial for newly diagnosed patients. That's somewhat of a different discussion, right? Because then you have the choice of standard treatment versus, do you want to try something that may or may not be better, right? It's not going to be worse, but we're not sure that it's going to be better.
Mm-hmm.
But when you're talking about relapse myeloma, that's where you do the phase 1 trials and new drugs. And the phase 1 trials all have the requirement that patients have been treated with the available standard myeloma drugs. So it means that you've already had all the treatments that are readily available. So in a sense, that discussion, when you come to those trials, is that you've already kind of tried the the standard option. So that's a much more different discussion. And quite frankly, then it's more that there's a much greater need for the trial.
Right.
And then it's really about, do I qualify for the trial?
Right. Thank you for that. Why don't we, I'm looking at the clock, and we have a lot of questions in the queue too, and I want to make sure that we're allowing people to get to those questions. And I know you already touched on some of the highlights from ASCO, some of the exciting news on BiTEs and Cartitude with Cilta-cel and others. Anything else? And a last question before we transition over to the group. And I know there's going to be some opportunities for the Best of ASCO presentation. So this is really breaking news. I'm not giving you a lot of time, but are there any just quick things that really kind of were so extraordinary about ASCO, or that you want to share with the group?
I think the progression-free survival of the Cartitude Janssen CAR T is really about 22 months now, which is amazing.
Right.
And the response rate still being so high, again, very, very exciting. So that's I think one of the things that was a take home. The good thing, there was a little concern about this Parkinson-like neurotoxicity that was seen in about 5 or 6 patients. That only has not seemed to have occurred in more patients. So that was encouraging. I think what they also showed is we just learned more about it, of how to sort of prevent that. So they figured out who gets more neurotoxicity so that will help us down the road in terms of strategies against that. So that was one big thing. The other thing was the bispecifics. So there were 2, teclistamab and elranatamab, which are both BCMA directed bispecifics, and both showed response rates. So, teclistamab was about 65%, elranatamab was about 80%. And again, heavily pretreated patients. I think with the teclistamab patients that had 6 previous lines of therapy, the elranatamab, I think it might have even been 8. So just incredible. And to get those responses, again, incredibly exciting and encouraging. And safety wise, it was something where, again, I think it shows us that, we can manage the safety. There's something called cytokine release, and that was very manageable again. So I think that was a good thing as well. Those bispecifics, and Dr. Berdeja presented a different target, something called GPRC. So that was exciting because that's a new target, and we actually have CAR T cells against GPRC as well. So we just opened a GPRC CAR T trial. GPRC is a protein that's expressed on keratinized tissue, so hair follicles, nails. It's also in the salivary glands to some extent. So it's interesting, but it's also in myeloma cells at very high amounts. So that's why that drug also showed a response rate of about 70%.
Wow.
So I think that's exciting because that's a new target. And then again, you can go after that with a multitude of agents. So that was a great one. There was another abstract, just again, for us as transplant doctors, really cementing that transplant, especially even for patients with high risk myeloma, is the thing that kept people MRD negative. So getting them to minimal disease state, and keeping them there. Transplant's still the best option for that. And then there was a study from the UK in patients who have ultra high risk myeloma, so defined as patients who had either plasma cell leukemia, patients who had very high genetic risk profiles, using an incredibly intense regimen. And that showed very encouraging results in terms of response rates, about 80%. And again, the follow-up is relatively short, but patients, seem to be staying in remission with that. So that was also really exciting. So, I think a lot of good stuff came out of it.
It's really, I think, when you hear that, new targets, new types of drugs, evidence on stem cell transplant, there are great reasons for myeloma patients to have hope. It's not just false hope. There is a lot of good reasons to be hopeful about the future if you have myeloma, and you guys are setting the standard of care and moving it forward. So thank you for that.
Well, thank you for everyone, and to everyone who also participates in the trials. We realize how difficult it is to be on a trial. I mean, we ask you to jump through so many hurdles, and again, we really mean it when we say thank you to the patients, because you're not just helping yourselves, you're helping so many other people as well. We learn from every patient. I mean, I can tell you with GPRC, when we started, we didn't know the toxicities in terms of the nail toxicities, some of the taste changes, so we learned as we went along in terms of, oh yeah, this is expected. Oh yes, this is something new. This is, so again, we thank everyone who really, takes that leap in terms of participating and bringing in those 24-hour urine containers every month.
Oh my God.
So
why don't we open it up to the group here and let, we have some questions in the chat. And why don't we give you a moment, Dr. Krishnan, because you've been.
Well, I think Audrey can read the
Audrey can
question.
See,
yeah.
But if you can see them too, Dr. Krishnan, you can see if there's anything that jumps out that you want to take on there too. We have.
Let's start with this one. I think it's a great question. As we're gradually exiting this pandemic, what are your thoughts on myeloma patients and their families easing precautions?
That's a great question. I mean, so the IMF has a sheet that we've been handing out to patients, just assessing risk for events. I mean, ultimately, to be honest, if you want to be the safest, don't leave your house, right? I mean, that's the bottom line. So everything beyond that really becomes, how comfortable are you? I mean, it's really an individual decision in terms of your level of risk that you're willing to take. So, I mean, the IMF sheet sort of says, okay, highest risk, obviously going to a large sporting event, you know, medium risk, getting on an airplane. So are we going to say, don't get on an airplane? I mean, that seems a little bit unrealistic, right? So I think it's more than then you have to decide, am I willing to take that risk for myself, right? I know that it's not extremely high, but I know it's not zero risk. And that's kind of, unfortunately, I think how life is going to have to operate for the near future. And
Yeah. So we've had a lot of great questions. Thank you for that answer, Dr. Krishnan. We've had a lot of great discussion about CAR T, and we have a patient who is high risk on first relapse and has never had a stem cell transplant or CAR T. Would you lean, when she does have that first relapse, would you lean towards a stem cell transplant or a CAR T, especially since, not for her specifically, but in your patient treatment in general, for those high-risk patients, if they haven't had that stem cell transplant, would you immediately jump to CAR T?
So CAR T, to be honest, is very prescribed. We don't have the options of who to give it to in that sense.
Right.
It is only for people who have had 4 previous lines of therapy, and they even tell you, which ones they have to have. So it's not that we have any choice in the matter. Your insurance company is the one who's really going to dictate it. So,
right.
So no one right now in first relapse is getting CAR T cells.
Yeah.
Bottom line.
Awesome. Thank you.
Hey, Audrey, I see. Can we maybe take 2 questions at once here? Because Sally has a question regarding share your thoughts on MRD testing and diagnosis and maintenance. And then Jackie had a question regarding the role of mass spec.
Yeah.
So the MRD testing, as many of you know, we're doing it more and more. And there are different ways of doing it. The one that we've been using is next generation sequencing. So it gets sent to Adaptive Biotech in Seattle right now. And so it doesn't have to be a fresh specimen, which is nice. We actually today, ironically, had a discussion with our new chair of pathology that we're going to start looking at doing MRD by flow cytometry in-house as well. So, and that's another validated way of looking at it. That needs a fresh specimen, so it's a little bit different. And again, you have to look at how sensitive the test is. So the Adaptive Biotech is 10 to the -6, so it's the most sensitive test we have. And most of us think that that's probably the most, to getting to that level of sensitivity really is what means something. Do we use it? Sure, we use it in terms of, it's a prognostic tool right now, meaning that if you become MRD negative, we know it's good. What we don't know still is really, when do you change therapy based on the MRD results? So there's a couple studies that are going on right now. There's something called the Auriga trial, which is using those results, basically MRD testing after transplant, to decide, do you augment therapy or stop therapy? And the same with the SWOG S1803 trial, which I'm chairing, same thing. So we're excited about those trials because it'll finally tell us, can you use the MRD results to help figure out treatment? So, but as you know, doctors are cautious too, in the sense of, we want data before we really make solid, paradigms in terms of treatment. Also down in the future, sure, it'll be, if you're MRD positive at this point, you need to do X and Y. If you're negative, do X and Y, but we're not there yet.
I think that actually gets to another question that I know people always have, is how long should I stay on maintenance? And I think that SWOG trial with MRD testing will at least provide some additional insights, right?
Yeah, exactly. And it's still a controversial question. As you know, in Europe, they give Revlimid for 1 year. In the US, they give it indefinitely in the absence of side effects. So which one is right?
Yeah. There's a question from Clifford. Do you have regular weekly or monthly myeloma review board meetings to review patient treatment?
So we have actually 3 myeloma meetings a week. We have a disease committee meeting where we review all the patients on clinical trials, and we review all the transplant patients. Then we have a research meeting that we just either have visiting scientists, we review our own research, work on grants together. And then we just have a sort of just a general kind of operations meeting as well. And then obviously all the national, international meetings, which are, let's put it this way, European Hematology meeting for Californians is not good. It's 3 a.m. So
Yeah.
So you have a diverse group there that actually works as a team, it sounds like, to review all of that.
Yeah, and I have to say, when the team is really operational, or many of you know our research nurses who are incredible. We are really lucky. We have such a great team of research nurses. I mean, I send them emails on the weekends and they are answering. And we actually, a lot of the research nurses have left some of the other teams who will remain nameless to come to myeloma. So we kind of very lucky. And many of you know the auto transplant nurses, a couple of them also kind of defected from other teams to come to myeloma. So, again, we're really lucky that way in terms of what a great group, all of them, and how dedicated they are. I mean, they get on the conference calls with me at 7 a.m., which again just says a lot. And some of our research associates, they all have young babies and they're still on the calls doing things. So it's really the whole team. I don't want to say it's just the doctors at all. We couldn't do it without the rest of them. So we're really lucky that way.
Hey, Audrey, do we have any hands raised for anybody that has maybe a question they want to speak out?
No, but anybody's more than welcome to. There's that raise hand button at the bottom. While we're waiting for people to raise their hand, if they feel comfortable, if not, let's keep talking. Jackie, I was just going to read your question, so you're more than welcome to unmute yourself and talk to her directly.
Hi, Dr. Krishnan. I was wondering how, you didn't answer the question on the mass spec. I was wondering how you feel about that test, and do you use it, and when do you use it?
So, I mean, it's a very good test. I was the second author on that paper, so I guess I do believe in it. So they took the trial that we did, the national trial, I tried to call the Stamina trial, and they looked at the traditional way of assessing complete remission and MRD and compared it to mass spec. So mass spec looks like it's actually as good as MRD testing, but it's a specialized test, right? So it's still, you need to have the machine, you have to have the training of the pathologist, even more than just the machine, to be able to read it. So obviously Mayo has switched everyone over to mass spec. There's a couple other centers that have, but it's still not widely adopted. It eventually might be, but I think it's going to take, you can't do everything at once, right? That's the problem in the sense of just hospitals and resource allocation. So you have to figure out which is the most important thing. So I was talking about MRD. Is that more important to us to have the pathologist do that, or to get them trained to do mass spec? You sort of have to pick. The nice thing with mass spec, which is a really important point as we start doing antibody treatment more and more. So as you know, for example, isatuximab, daratumumab are antibodies. Myeloma proteins are antibodies. So a regular electrophoresis, sometimes you can't tell, is it your myeloma protein or is it the daratumumab or isatuximab that you're seeing in the blood? Mass spec, that's not an issue with mass spec.
Oh, that's good. Okay. Thank you.
And then Jackie, did you want to ask your other question about relapse as well?
What's your philosophy, since the disease is obviously characterized by relapses? Should a patient kind of think about what they would do should they relapse? Should that be a point of discussion?
Well, I think, I guess it depends where you are in your treatment course, right? I mean, for example, if someone is newly diagnosed, it is a discussion in terms of if you're thinking about transplant or not, because, we do talk about the option of, what's the best time to do a transplant. But I don't think you can plan. It's not like chess. You can plan 3 moves ahead. And some of that's in a good way, because as we've talked about, the field has changed so quickly. So if you ask me, well, what will you give me next? Well, first of all, initial remissions with myeloma generally last a long time now, which is great news, right? 4, 5, 6 years. So things may be completely different in 6 years. CAR-T may be approved in first relapse, for example. So, I think I always think about deal with what's kind of in front of you right now, because you really can't predict what's going to happen in the future to that degree that it's going to, be meaningful.
Right. Thank you.
Awesome. Thank you, Jackie, and thank you, Dr. Krishnan. Sally, I see that you have your hand up if you want to unmute and talk to the group.
Good evening, Dr. Krishnan. I was just wondering what your feeling is MRD monitoring. How often should it be monitored?
That's a great question. That looks like such a comfortable chair. I'm jealous.
Well, have to be comfortable.
So, I mean, you're right. So there's this concept of sustained MRDs. In the International Myeloma Working Group criteria, it's at least 1 year apart sustained MRD. So, I'd say that's probably the time frame. Sometimes we do it more frequently. I mean, it's a catch-22. Sometimes you want to know, right? But it's a bone marrow biopsy. I'm sure if it was accessible by just blood, and there's new technology that we're working on, if it was just a blood test, I'm sure we'll do it much more frequently than that too.
Oh, sedation is the only way to go. So you're recommending at least once a year?
That's the guidelines from the IMWG in terms of what they consider for sustained MRD, right? So I think that's a reasonable time points.
Because I know clonosec is, talking about doing it every year just so they can map it and graph it.
So on the SWOG trial, at 12 months, it's optional, but we encourage people to do it. And then it's mandatory on the trial at 2 years, 3 and 4 years.
Okay. Thank you so much.
Dr. Krishnan, we have another question about patients with kidney impairment and how limited they are in terms of treatment options. I've actually heard this in a different meeting, that, Revlimid has a bad rap for being bad for the kidneys, but at the proper dose, possibly it could be available treatment. What is your answer to that question?
So that's another great question. So it is frustrating to us that most clinical trials don't include patients who have significant kidney impairment. They've gotten better. Some of the trials do allow some degree, but so that's one frustration. In terms of Revlimid, it actually is not toxic to the kidneys. It's just cleared by the kidneys. So you can't give full doses because then you'll get severe, low blood counts and other toxicities. So you just have to adjust the dose. But you can give Revlimid even to patients on dialysis. You just have to use the appropriate dose for it. I think it will have implications. For example, CAR T cells, the drugs we use to prepare people for CAR T cells, the drug called fludarabine, you really can't give in people with severely impaired kidneys. So there's no data in CAR T cells, for example, in people with severe kidney impairment. So there are specific scenarios where it could be, change treatment options for people because we just don't know yet in terms of if it's going to be much more toxic. The good news is you can do stem cell transplant in people even on dialysis.
Yeah, that is good news. Thank you. And then we have an interesting question. So they said you did an interesting allo transplant with a twin. What do you expect for that type of transplant? Is it a potential cure or is that overreaching?
So if it's an identical twin, we call it a syngeneic transplant. And what we know for syngeneic transplants is that the relapse rate is lower than using your own stem cells. But we still don't say cure, to be honest. And some of that may be as our understanding of myeloma gets more and more. Part of the reason we think people have or myeloma comes back is it's some deficiencies in their own immune system. And so, it's probably a function of more than just one thing, right? Of just clearing out myeloma in the bone marrow.
Great.
Yeah, I think that's an interesting thing too, Dr. Krishnan, is that I know some of your research is focused on understanding that exact question. Why does myeloma come back? And getting to the basic, some of those fundamentals will be so essential too. And thank you for doing that research too.
Yeah, no, that's something we're really excited. Dr. Picciori, who's one of our myeloma scientists, has really become extremely internationally known for her work on why do people become resistant to daratumumab. And what she's shown, for example, is it's not that you lose the expression of CD38, which is what people used to think, but it's also a lot of the immune cells around the myeloma cells that are affected that play in part the reason people become resistant. And so what that understanding resistance is important, because then it means you can then figure out ways to get around it. And so we actually have a couple of trials that we're in the planning phase with some really cool stuff. And we're putting in a grant, and the title of the grant is Overcoming CD38 Resistance. So specifically for this idea of if daratumumab stops working, how do you overcome that?
Wow, that's
As
awesome.
a DARA patient for the last 3 years, I'm glad you're looking into these things. I'm hoping it works for a really long time, and I know we have other DARA patients on here too. So,
Tom, I did see you raise your hand. Did you want to say something?
and I think, well, why don't we have this as one of our last questions here, so we can let Dr. Krishnan recover from ASCO and all of that too. So
I know it's Taco Tuesday. My husband's texting me from Bear Flag. Like, what?
Tom, what's your question? Tom, did you have a question?
Maybe he didn't. I saw him raise his hand, but now it's down. So
she actually asked my question about the twin. I do consulting for one of the patients that Dr. Krishnan did the syngeneic transplant on, and it becomes a conversation in the infusion center, because people are thinking under those circumstances, all of the cells are gone and the cells are coming from the new person. So how on earth can myeloma still be there? But your answer to that was an interesting question that goes beyond just the cell.
Yeah, I mean, there's something called graft versus myeloma effect, right? That's really what we're saying. That's in the immune effects. That's why you think about all these new therapies. It really, CAR T cells is not a surprise to transplant doctors, because we always knew that T cells, that's what allotransplant is. You're using new donor T cells, right? And it's the same kind of idea that you need immune effects as well to keep cancer from coming back.
Yeah. Thanks.
Hey, Dr. Krishnan, I think every time I spend time with you, I'm just always so grateful and blown away by the depth of knowledge that you have in this space and your passion for it. But the other thing that I always appreciate is that you're just an awesome person too. And it's nice to know the other side beyond just your expertise in myeloma. So I've got a question about Dr. Krishnan outside of myeloma. What's your go-to on Taco Tuesday? Where do you go and what do you order? That's my last question for you.
Bear Flag. I'll always go to Bear Flag. That's
Bear Flag for what?
I don't know if you guys have them in South County, do you?
Yeah.
At Huntington and in Newport. Yep. So what's your go-to? A good fish taco there?
Oh yeah, fish taco. My daughter's the poke bowl, but we're a fish taco all the way.
Right on.
Awesome.
Well, thank you again. From all the people that are on the line, can you give her a warm, muted round of applause? And
yeah. Thank you, Dr. Krishnan.
Thank you again.
See you guys Thursday.
Yeah, we'll see you Thursday. Oh, and that's good news. This might be breaking
Dr. Krishnan,
news.
for everything you do.
Dr. Krishnan has said that one caregiver is allowed in with patients at City of Hope.
I know. Okay, let me just clarify that though. At the Newport, so the satellite clinics, but not at the main campus yet. because I think that has to do with waiting room space, really.
Right, that makes sense.
With how big the clinics are on main campus, they don't be able to distance people. But
well, I've been waving at you from the car since March or April of 2020, so I'm excited. I get to see you in person on Thursday.
I mean, there's some new patients we've had I literally have never met.
Amira, yeah, it breaks my heart to think of that. I was happy that Todd was in remission during that period. I can't imagine if that wasn't the case. So, thank you.
So, awesome. Well, have a great night. Thank you. Everybody else, hang on. We'll say good night to you, Dr. Krishnan. See you real soon, and thanks for joining.
Yep. Have a good night, everyone.
Bye.
Bye. Well, that was awesome. Was that helpful, folks? Yeah?
Of course.
She's awesome.
Awesome. Yeah, we got a good crowd attending here, and then we have another 40 or so people that are going to be able to benefit from, hopefully, from that conversation and listening to a recorded version of it. A lot going on, and we are very, very fortunate to have her, as well as, experts at Cedars and at UCSD and throughout the Southern California area. So, Ben, it's good to live in Southern California, and it's certainly good to be having this diagnosis now with such a bright future ahead. And I think one of the things that was so important was the education side. Yeah, Sally?
I was just going to say, it might be a fun poll to find out how many of Dr. Krishnan's patients are on here today.
Yeah. Can you do that one quick for us? Just Audrey can do a quick poll. We'll go. And while she's setting that up, I can give the review of just the quick here on the June calendar. There's a lot of great things that are coming up, but if you can only attend one thing, I'd really look to that June 26th from 8 to 11. You'd get the benefit of hearing the greatest info from both the European Hematology Association, plus also ASCO that Dr. Krishnan was speaking a few things about, and some of the speakers that are, they've divided into three speakers at the beginning. They're going to talk on the European Hematology Association, and that's Dr. Martin Kreiser, Dr. Van de Donk from Amsterdam, and then Dr. Wiesel from Hamburg, Germany, and then in the second half of the presentation, the last 90 minutes, is going to be Dr. Faith Davies, who's from New York University, Dr. Gertz from Mayo Clinic in Rochester, and then Dr. Craig Hoffmeister from Emory in Atlanta. So that's a great upcoming one to mark your calendars for, but then all sorts of great things that you can see there also. Did you get that poll up, Audrey? Yep. All right. So if we can do the poll while you have to scroll down to be able to see the third poll. And we can see how we're going there. So far we have 7 people voting, and we'll see how it goes there. And we'll let that one keep going. Audrey, if you go back one slide, if possible, to the July calendar. Again, something I want to point out, we're not going to be meeting this July. There's quite a few myeloma coaches that are on this call that live in Southern California, and Todd and I know Sally, and I believe Jackie will be participating in the Myeloma Coach Summit, which is going to be in Utah. So we will not be in town. We will be meeting just separately, and then getting lots of great information to help us come back and close out the year super strong. But there's, again, some fabulous events happening in July, and I would encourage you just to keep your eye on that Myeloma Crowd events page, because things do change and things are added quite frequently, as Audrey can attest. Looking at the votes over there, we got 9 yeses for Dr. Krishnan, 4 no's, and 1 maybe in the future. So quite a Dr. Krishnan crowd here tonight. And then for the August, August calendar, we are planning our next meeting as August 10th, 6:30 to 8, and that one it will be unleashing the power of HealthTree Cure Hub. So Todd Foster is going to be our guest speaker and really talking about some of the benefits for all patients through that Cure Hub. So that's exciting news. Then something we always talk about are the main myeloma organizations, and we cannot stress strongly enough the value of all of these organizations here. And we'll attach this sheet that we made, this You Have Multiple Myeloma, and we encourage you, City of Hope is using this at their Duarte campus. I know Tom has brought it in, and they're using this at Eisenhower. That has a doctor that they would bring it to, and it can be in an infusion center, it can be given to nurses. We all know what a hard thing it was when people are initially diagnosed with multiple myeloma, but to direct them to valuable resources right at this first step would be amazing. So these are the main organizations that we always promote. And then with that, on the next slide, here's some upcoming things that are happening. The IMF is great with support groups. I know Jackie just led the IMF for Orange County, and we had Dr. Duarte on that, and that was fabulous. So there's links, because I know we have people on this call from San Luis Obispo down to San Diego. So there's the link for other local support groups that are just in your local region. And then again, one thing I really want to point out is the NMRF is having their highlights from ASCO, and that's a 1-hour abbreviated version. And that's going to feature Dr. Krishnan and Dr. Jesus Berdia, who's from Sarah Cannon in Nashville. And that one, I have really struggled with finding that link on the MMRF page. So if you can't find the link, go back to the slide. You'll get them tomorrow, and it's right there for you. If you click on that link, it'll get you to it. All right. And then this is an important one from the Leukemia and Lymphoma Society. We've talked a lot. There wasn't as many questions on COVID this time, but everyone's curious, what are my antibody levels? And there was the Johns Hopkins study, but this is another one, and they are actively still enrolling. Todd's participating in both the Johns Hopkins and this one through LS, and I've put the link on it there. It'll take you to this page, and you can register. Todd, do you want to give any more details on that?
I think the nice thing about this one is that they're doing 2 different antibody tests. So like the Johns Hopkins ones is only doing one that's a relatively basic, helpful, but relatively basic. The LLS one is doing 2 different tests. And you can, if you're in both, you can bring both use LabCorp. You can bring the same order to your appointment at LabCorp, and they'll do it, and it costs you nothing. And the other important thing about this is the caveat on this is you don't know. You get your antibody levels back, but you don't know what that really means. Does that mean I have a sufficient immune response to the vaccine? But by participating in this trial, it will help us get to the answer. So you'll get some information that should be directionally valuable, but you'll also be contributing to answering some critical questions for our entire myeloma community. So if you haven't considered this, it's a great thing, and it costs nothing. So highly recommend that. And I was going to tell you one other thing, Diane, on the community events calendar to looking forward. So in August, we'll have Todd Foster talking about Cure Hub, but in September, for those of you on here that are from San Diego, we have Dr. Fotis is the first name, and a very long Greek name that goes with that. And I see somebody smiling because you know exactly who I'm talking about. And I'm going to have to figure out how to pronounce that. But he's agreed to chat with us. And one of the reasons we asked him is because in our very first meeting, we presented some of the Cure Hub findings around some of the critical questions that people had. And a lot of people do have questions in particular around genetics. And what do I need to know about genetics? And Dr. A, or Dr. Fotis A, he's an expert in that arena, and he's going to help us. So you'll look for more information on that.
If you're not interested in the genetics, he is one of the funniest people there is on the planet.
Yeah,
that's true too. That's the extra bonus of joining that event. A little Comedy Central and myeloma.
That's right. Unusual combination.
Yeah.
We'll have to think about how we can promote that in our outreach.
Yeah.
It's true. It's true.
Open mic with your myeloma.
Dr. Fotis.
Exactly.
All right, Diane, sorry to interrupt you.
No, that's it. So just mark your calendars, no July meeting, but definitely please join us August 10th. And we'll maybe have this whole Google Meets thing figured out or not. They will have changed it again by then, so who knows.
We're switching to Zoom.
We are as soon as we can.
I think at this
I'll
point,
go for that.
we are right on track at 7:45. And Audrey, you want to thank our sponsors, and then we can move over to the virtual mingle.
Yes, sir. So just another thank you closing out to our sponsors. Bristol Myers Squibb, Amgen Oncology, Karyopharm Therapeutics, AbbVie, Adaptive Biotechnologies, Genentech, Oncopeptides, and Takeda Oncology. And thanks to each of you for being here, helping us grow this myeloma crowd community. Just as Dr. Krishnan was saying about the clinical trials, that it wouldn't be possible without you. Same with these programs. They only matter and they're only cool because you guys come. So thank you.